Dear students, today we are going to discuss with you topic number 2, closed and open fractures, gunshot fractures, modern principles of fracture treatment, traumatic osteomyelitis. We'll discuss with you classification of fractures, basic principles of fracture treatment, including non-surgical and surgical modalities, gunshot fractures, and traumatic osteomyelitis. Let's start from fracture classification, as depending from the fracture type, we can choose proper treatment and achieve better results of treatment. So this is first type that we are going to talk with you. This is so-called hairline fracture. It is called so because the fracture line is very thin and it can be missed very easily by an inexperienced physician. So to avoid this, we should remember some certain rules. And first one is that thorough clinical examination should be performed before you administered an X-rays. Another thing is that if you make one X-ray, you can miss the fracture. To avoid this, you should do 2 X-rays, and this should be 2 straight views, AP and lateral views. In some specific locations, like scaphoid fractures, you should make another view even. It would be a 45-degree oblique view, special view for scaphoid bone. If you remember these scenes, you can avoid and miss the fracture. Actually, this fracture usually heals well because bone fragments are on their position and there's a good contact between them. So the only thing that you need to do for this case is just to apply immobilization. It may be a brace or cast, POP or polyurethane, but you should fix this fracture till the moment that requires for its healing, and that depends from the location. This is very common for childs, and it is so-called green stick fracture, as it behaves as usually a green stick behaves. So we have a angulation, and we almost never will have a shift of bone fragments. That is due to the very elastic periosteum. When the bone is broken, periosteum is not, and due to this, it can cause only angulation. So the very common site is that periosteum is broken only in one place. In another site, it is intact. So treatment for green stick fractures requires, for displaced fractures, reduction. Mostly we should correct angulation. And in some cases, we should break the opposite cortex as well to achieve proper fixation and to avoid redisplacement. And we should immobilize this limb in a plaster bandage in a cast. For childs, healing is usually quick, and delayed healing or non-healing is very rare. The fracture line can go in several common types. So one of the most simple is a transverse fracture, when a fracture line goes perpendicular to the axis of the bone, or up to 30 degrees of angulation. This fracture can be due to direct injury when force is applied to the fracture site, or it may be indirect injury as well. Next common type of fracture is so-called oblique fracture. The fracture line goes on some angle according to the axis of the body. Usually this angle is up to 60 degrees. So if we are talking about oblique fracture, it is mostly due to the indirect injury. So spiral fractures are another type of fractures that cause quite complicated pattern for treatment. So all these fractures are so-called unstable fractures because when they occurred, these bone fragments usually are displaced, and even after the reduction is done and plaster bandage is applied, for oblique and spiral and comminuted fractures, very common is secondary displacement. That's thing you should remember when you immobilize a fracture. Multifragmentary fracture is another type of a fracture when the bone is crushed in more than two fragments. Sometimes there are many small fragments, sometimes there is one big fragment lying between two main bone fragments. For this type of fracture, usually we have a contact between two main fragments, distal and proximal one. But the treatment of these fractures is more complicated, and healing is usually good due to the big plane of the fracture site. In AO classification, this type of fracture is classified as B group for diaphyseal fractures. Another type of fractures when we have also comminution and we have no contact between two main bone fracture fragments, we consider as more complicated type as C type, as these fractures are more unstable and they require advanced treatment. There may be some problems with healing of these fractures, so these are classified in AO classification as type C fractures. The next type of fractures is so-called double fractures, when you have fracture of the bone on two levels. The peculiarity of this fracture is that usually we have problems with healing due to poor blood supply of the central fragment, as blood vessels are damaged from both sides, from proximal and distal. Due to these, in many cases, one fracture plane is healing in delayed way. So another type of bone fractures is so-called impacted fractures. These are fractures of the metaphyseal areas of bones. This is usually neck or humerus or femoral neck fractures, and in these fractures distal fragment is driven into the proximal one. Usually these fractures are not displaced, as there is some stability at first time, but later red displacement can occur. So these fractures require stabilization. It may be done with a plaster bandage for upper extremity fractures. For lower extremity fractures, for femoral neck fractures, we usually fix them with cannulated screws. So the next type of fractures is so-called compression fractures. These are fractures very common for cancellous bone, and the commonest locations are calcaneus fractures and vertebral body. So these fractures are common from the falling from the height, and in many cases the cancellous bone is jammed due to the intensive force which is applied along the axis of the body. So in most of the cases we have some compression and impaction of this bone tissue, and the healing of the fractures is usually good, but the thing that we should do, we should restore the height of the vertebrae if it's possible, and immobilize the fracture. So next type of fractures is so-called avulsion fractures. So these fractures are caused by a sudden muscle contraction which cause avulsion of the a small piece of bone at the place of the muscle or ligament attachment. We have the common areas when it can occur. These are the base of the fifth metacarpal bone, maybe a pole of patella or lesser trochanter. Also, avulsion fractures are possible at hands. In hands, when we have attachment of the capsule, dislocation can cause avulsion of this area. Another very common area is malleolus fractures. The tip of medial malleolus can be avulsed as well due to some abduction and rotational forces. Next very common type of fractures, impacted fractures or compressed fractures. It's common for skull injuries. The fractures also can be classified according to their location to the joint. So, as on the right slide, you can see the fracture which is close to the joint, but it is not involving the articular surface. And it is possible when joint is involved, it may be a partial involvement or complete involvement. Of course, this will affect significantly on the treatment and outcome. As for fractures that are involving the joint surface, first of all, we should achieve precise reduction. Otherwise, further development of osteoarthritis is very common. So mostly this is done by surgical technique, as only open reduction, internal fixation can allows us to achieve very good positioning of fracture fragments. So the fractures that are involving the joint surface are classified according to the AO classification as B group and C group. So for C group, the articular surface is totally involved and crashed, and for partial involvement of articular surface, this is a B type of these fractures. But even if the fracture is not involving the articular surface, but it is located close to the joint, it will also later cause some complications, as joint stiffness. Because to immobilize this fracture, even in non-surgical way, we need to apply POP, and joint motion is impaired. So prolonged rehabilitation period is required later. Next very common type of injury is so-called a fracture dislocation, as you can see on the left slide. So this is a combination of actual two injuries, fracture and a dislocation. It is very common for shoulder joint, and actually the shoulder joint is presented here. We can see here inferior dislocation of the head and a humeral neck fracture. Well, so what is the problem with these injuries? So usually, if we have just a dislocation, we should perform a close reduction. And in fracture, if fracture is present, there is no possibility to use distal part of a limb as a level, and the reduction process is usually very complicated. So this is an urgent condition and should be managed as soon as possible. You should reduce dislocation, and then you should reduce the fracture and put it in the anatomical position. If you look on the right side, we can see here an illustration for so-called complicated fracture. So many students think that complicated fracture is a fracture when we have many small bone fragments, like bone was crushed in many pieces, and they call this as a complicated pattern. But truly speaking, the complication, we mean that there is a injury of some very important structures that are located in this area. So in this case, there is an illustration of damage of the artery, and other structures like nerves can be also damaged, and this would be a complication of a fracture with a nerve injury or arterial injury. As well, a complication is considered when we have a closed fracture that was not properly immobilized and further redisplacement occurred and the fracture becomes open. So we consider this as a complication as well. When we start our treatment for fractures, we should account different important factors. One of these is the location of the fracture. So the fracture may be a shaft fracture, a fracture of the epiphyseal areas and metaepiphyseal areas. And according to the location of the fracture, we should choose the correct treatment. Another important factor is the age of the patient. As we know, for young patients, childs, the fracture healing is very quick, and for old patients, it may take much more time. The next thing that we should consider is a pattern of fracture. So if the fracture is transverse, oblique, spiral, or comminuted, that can affect on our choice of the fracture management. As well, we should consider such things as displacement of a fracture. So generally speaking, if fracture is not displaced, we should just immobilize it with a cast or brace. But if the fracture is displaced, we should reduce this. So displacement may be complete displacement, and when there is no bone contact between fragments, and this type of displacement is not good, as the fracture may never heal in this condition. And maybe a partial displacement. So maybe a partial shift, and when there is a contact between bone fractures. And in these cases, the fracture will heal, but will heal in incorrect position. As well, there may be some problems with function of the slim plate. Maybe for unstable fractures, it is possible that the fracture goes with some shortening of the limb. And if we are talking about upper limb, that will have just cosmetic defect mostly. But for lower limbs, the patient won't be able to walk normally. The worst displacement that we should obviously correct, this is angulation. So it may be angulation to the anterior part, to the lateral part, or medial part of the bone. And you should know that there are some physiological curvature on each of the bone. And when this curvature is increased, or the angulation goes into the opposite side, in many cases, this position of bone fragments is considered to be unacceptable, and we should correct this. Another common type of displacement is so-called rotational displacement, and sometimes it's hard to determine this on plain X-rays, so full-length X-rays are needed in this case, and clinical examination will help us to find out that such displacement takes place. So in many cases, we should correct this displacement. And another very important thing that we should consider in our patient with a fracture is it open or close. So if we have some wounds in this fracture area, that's usually will cause the infection going inside of the fracture, and the infection can impair the fracture healing and also can cause such a complication as osteomyelitis. That's many treatment options that are usually used for closed fractures we don't use for open fractures. For severe open fractures, we don't use plating, we don't use intramedulary nails. But on the other hand, we should use fixators, which we call external fixators, when metals, screws and K-wires are inserted besides the fracture side, besides the wound side. On one side, it's good for fracture healing because fracture is stabilized. Second thing, it's good for wound healing because when there is no movement at fracture side, there is no irritation of the wound, and wound usually heals well. So if we're talking about fracture treatment, most of the fracture displacement types should be corrected, especially gross displacement. That's you should correct, first of all, angulation, you should correct the length of the limb, you should correct rotation. And if possible, you should correct the shift of bone fragments. You should know that if the fracture is shifted but not completely, and there is still contact between bone fragments, the fracture will heal. But the main point is the axis of the extremity. So if the axis of the extremity is good and there is no shortening and there is no rotational displacement, the function of the limb after diaphyseal fracture will be completely restored. So now we will talk with you about principles of fracture treatment, about indications for non-surgical and surgical management. We will discuss with you different peculiarities of various techniques, either this is a manual reduction, or skeletal traction, or POP application, or surgical modalities like internal fixation with plates, nails, screws, or external fixators. So, of course, our treatment for fractures starts from the place of injury, so-called prehospital management. And that is very important, because if it is done correctly, the further prognosis will be well. Any mistakes, any problems on this period of treatment will cause further complications and will decrease the successful rate of outcome. So, of course, we should immobilize extremities. We have to use various splints. We'll discuss this later. We may use any material, any hard material you have around you. It may be a stick, an umbrella, a wooden board, a branch of a tree, some hard paper. You should also give some analgesics, because every fracture is painful, especially if you have patient with many fractures, multiple fractures or polytrauma. You should give powerful analgesics in this case. We should check whether there is any wound in the fracture side or around the patient body, and if it is present, you should manage it as well. We should also apply ice on the injured limb and elevated position of a limb, as these simple measures will help to prevent development of swelling. And we should take this patient to the hospital as soon as possible. So let's talk a few words about how to immobilize limbs properly. And this is an example for upper limb. You see so-called Kramer wire splint is used. So first rule is that the limb should be immobilized in physiological position. So for upper limb, this is a position of 90 degrees flexion in elbow joint and middle position between pronation and supination. In this position, the muscles of a limb are relaxed and pain is less. So you see that this Kramer wire splint can be bended and modulated according to the shape of the extremity. And here we should, on the inner surface, we should put some soft padding to prevent the compression of soft tissues, because in all cases the swelling is increasing in fast hours. So to prevent damage of soft tissues by means of these wires or the hard splint, we should put some soft material underneath. So here the proper technique of forearm fractures is shown, as you see that elbow joint and wrist joint are fixed. So this is the main principle of immobilization, that we should immobilize two nearest joints of the fractured fragment. Next image show you that if you don't have a splint, you can use a sling to support this limb. It can be used for forearm fractures, it can be used for fractures of humerus. On this slide you can see that these Kramer wire splints can be used for lower extremities as well. That's even for femur fractures, as that's not the best option, of course, to immobilize femoral fractures, but it's quite a good option if you don't have other splints. But for femur, for hip joint fractures, we will discuss later which splints should be used. Actually, for tibial fractures, for foot fractures, these splints can provide quite a good fixation, and you see that we should bend the splint and the level of knee joint to relax the muscles of the thigh and the lower leg. And in some cases we can use 2 or 3 splints. One is applied posteriorly, one is on the inner side, and another one on the outer side. So the next common splint that is used to immobilize hip fractures is so-called Dieterich's wooden splint. It has several parts. From left to right you can see the inner part, the outer part, the part for a foot, the stick, and on the next slide we will show you how the splints work. So we usually, you know that the rule is, when we want to immobilize a fracture, we should immobilize proximal joint and distal joint. So for hip fracture, it's not easy to immobilize proximal joint because we don't have it. So due to this, we have a splint which goes to the axillary region on the lateral side. On the medial side, it goes to the groin region. These two parts are banded together with a bandage, and below we should also apply a special traction device, which is very simple. We have a stick, a rope, and support for a foot. So foot is fixed to the support with a bandage, and then you can twist the stick, a rope, and apply some traction for this extremity. These very simple measures will help to immobilize femoral fracture, and the mortality rate will be decreased. So let's talk about main non-surgical and surgical ways to treat a fracture. So as you see, for non-surgical treatment, we're talking about mostly about different types of immobilization. Very important is a functional treatment with a continuous skeletal traction. We can use also manual reduction, which is used for displaced fractures that we can reduce and fix with a bandage. And also, you see on the last place, we put so-called drug therapy. So this is various analgesics, non-steroid anti-inflammatory drugs, antibiotics if surgery is done, calcium, vitamin D, and so on. So if we talk about surgical method of treatment, This is divided into big groups. First is internal fracture fixation, when we insert some implants in the fracture site, and these implants are fixing the bone and are preventing its movement. These implants may be plates, intramedulary nails, that's mostly for shaft fractures, and maybe screws, wire circlage, Kirchner wires. If we're talking about external fixation, there are two main types of such fixators, like ring frames and rod external fixators that we'll talk with you later. So this is like an algorithm, basic principles what you should do with a patient with injuries, especially if we have a severely injured patient with a polytrauma or concomitant injuries. So you see, on the first place we put the saving the patient's life. So even if there is some deformities of the limb, but the severity of the patient's condition is very bad, so you should take care mostly about stabilizing his general condition, not about correcting these deformities. But if the patient's general condition is good already, now you should go to saving the extremities. And this is the secondary goal for us. The primary was to save the patient's life. So if you are able to save these extremities, the third goal is to restore the anatomical structures and fractured bone. That means that you should correct all main types of displacement and restore the anatomy as good as it is possible in your situation. And the last goal is to restore the function of injured organ. So, because you can restore the anatomy very well, but if proper rehabilitation was not performed, there may be problems with function. So let's start to talk with you about non-surgical methods of treatment. And on the first place, we'll talk about so-called closed reduction or manual reduction. And this is usually used for displaced fractures, of course. After this, we should immobilize the fracture with some kind of device. It may be a brace, it may be a cast or POP bandage. So actually, it goes in several steps that you should remember. And if we are talking about the displacements, you should correct length of the extremity, you should correct angulation, you should correct the displacement, the shift of the fracture, if it is possible. But for intra-articular fractures, you should restore the articular surface precisely. So that's an example how it is usually done. The very common fracture, distal radius fracture, have many of these almost every day. So we should first of all give a local anesthesia. For these fractures, we used mostly local anesthesia. We are cleaning the skin with antiseptics. We're injecting lidocaine solution just directly in the fracture site. So if you see the blood in your syringe, you are sure that you are inside, and you should inject some amount of lidocaine solution into these areas. Maybe 10, maybe 12 milliliters of 2% lidocaine solution. Usually it's enough for proper anesthesia. And waiting 5-10 minutes after this, you can perform your reduction already. As I told already, it was 3 main steps that you should do. And first step is just traction. You apply traction along the axis of the fracture. So you need an assistant for this. You're pulling for a hand, for 4 fingers in the first one, and your assistant is pulling on the opposite side, taking patient's elbow joint. So you're doing this traction for some period of time, like few minutes, to relax the muscles and to correct the shortening of the fracture. Then you should correct the main types of displacement, as usually this fracture goes with dorsal displacement, and you should correct these. You should correct also rotational displacement. And the third period of treatment is so-called retention. So you should keep fracture in this reduced position until you will apply POP bandage or cast bandage, and this POP bandage will harden. So for cast, polyurethane casts, this period takes more long time, takes sometimes 15-20 minutes even. So you should keep fracture in corrected position and prevent its redisplacement. Of course, after this manipulation, before and after, you should make an X-ray into views to be sure that your reduction was successful. This is another way how we can perform manual reduction, but in some cases you should apply much more force and for a more long period of time than you can do. And another reason for this type of reduction, when we use special device, special apparatus for reduction. Actually, here we see a so-called Sokolovsky apparatus that is used to fix the distal part of humerus and fingers and distract the forearm fractures. So if you don't have an assistant, you can do it by your own by means of this so-called apparatus for reduction named by Sokolovsky. So these are several types of plaster bandages that you can apply. You know that we can apply a circular bandage, we can apply long posterior cast, and you see that even if the fracture is open, we can apply a plaster bandage, a circular plaster bandage with a window, but of course it's not a good option. So we talked already about these things, that in these cases of open fracture, we should better use external fixator. But if you don't have it, or there is no possibility to apply it, a circular plaster bandage with a window, which will allow performing dressings, to check the wound state, to remove sutures. So this plaster bandage can be applied. Note that in some cases we apply not a cylindrical POP bandage, but posterior cast, which is shown on the right part of the slide, or maybe anterior cast, which is not circular but semicircular. So what is the idea of these? Of course, we understand that circular plaster bandage is very good to and is fixing bone fragments much better, and it can help us to prevent displacement much better. And in all cases, when we are doing reduction, manual or by means of apparatus, we should apply a circular bandage with a padding. But in some cases, if the edema is increasing very quickly, or you can't observe your patient, you can't look for this limb, in some cases it's better to apply a non-circular bandage, because when swelling is increasing, the soft tissues, nerves and arteries can be compressed inside, and you may have a problem with this patient later. So these are rolls of POP that you usually put in water, and you can make of them any design of POP as you need it according to the fracture pattern. Remember, the principle is the same and we are applying splints. So if you have a fracture segment, proximal and distal joints should be immobilized. There are some exceptions when we don't immobilize one joint, what we call so-called functional bandage, but this is specific cases that we will talk with you later. So you see that lower extremity and upper extremity, they are fixed with the POP bandages, and we have special devices how we can cut this bandage when we are removing this or relieving it. Note that fingers of hand and foot are visible, so we can see these fingers, and this is done specially for some reason, and that is very important reason, because when POP is applied, we should check the blood supply and sensation on the distal part of the limb. So for these, tips of fingers are usually made visible, so you can touch them, and if they are warm of normal color and sensation is present, then you're sure that everything is okay. But if there is no sensation, they are pale or they are dark or they are cold and there is no sensation in the fingers, so that is a very important sign. That means that you should remove or relieve this POP immediately. Otherwise, you may have ischemic problems or nerve problems with sensation in these patients later, and that would be very hard to treat. So now let's talk about so-called functional fracture treatment, and this treatment includes skeletal traction, glute traction, adhesive traction, and sling traction. These functional treatment don't provide as good fixation as bandages, but it gives us another advantages, as we can immobilize unstable fractures. And another point is the joints are not immobilized, that we can perform, patient can perform movement in these joints. And of course, the stiffness is absent after such treatment. So this is a scheme of a skeletal traction, which is applied for upper extremity. Note that there are several types of fractures that we can treat. We can't treat forearm fractures by means of this method, but we can treat fractures of the humerus, maybe supracondylar fractures, fractures of the humerus shaft, neck of humerus, and even fractures of the scapula when intra-articular surface is involved or scapular neck is fractured. Note that this is a whole system of skeletal traction. It can be done in two different ways, the left side and the right side, but the main idea is that the main force is applied along the axis of the humeral bone. There are some additional slings and some additional forces are applied along the axis of the forearm, and also if we need to correct some shift of the humerus, we can apply some slings and correct this displacement. So if we are talking about procedure, how to apply this skeletal traction, we should remember that we should put the K-wire through the bone, and the only place where you can do it for upper extremity is olecranum. So you're doing this as a surgical procedure. You need sterile instruments, you need sterile K-wire, you are cleaning the skin with antiseptics, twice with iodine solution, twice with spiritus. You are injecting lidocaine solution in two places. One is middle part of the olecranum, where you are injecting 4 to 6 milliliters of lidocaine, and the lateral part where you are going out with your K-wire. So after this, after local anesthesia, you may use a drill and put a K-wire through the olecranum. Then later a tension bow is attached and a weight is attached along the axis of the humerus. This is a scheme for low extremity. We can apply it as well for fractures of the femur, fractures of tibia, fractures of pelvis, acetabulum even. And this is a quite effective method. It's non-expensive method, and in many cases, for many fractured patterns, it can lead to good functional results and good healing. So let's talk about the main places where you can put K-wires. So these are supracondylar area of femur, tibial tuberosity, that's actually the most common place where we apply K-wires, calcaneus, and supramalleolar region. So as you understand, this method, this K-wire, is applied not through the fracture side. It is usually applied distally, so distally from the fracture side. And if femur is broken, we usually apply skeletal traction through the supracondyles of femur or through the tibial tuberosity. If the tibia is broken, we usually apply a skeletal traction through the calcaneus. The technique is the same as for upper extremity. The only thing you should remember that for supracondylar area and for tibial tuberosity, you are inserting the K-wire from the lateral side. When you apply skeletal traction through the calcaneus, you are inserting a K-wire from the medial side. Here you can see the scheme for the most common types of skeletal traction that we used, except the skull, because we are not applying the skeletal traction in our discipline. It's maybe more about neurosurgery. They have a Helios system, not like this one, more modern system, but this is another talk and for another discipline. So let's talk now about surgical treatment, and actually all surgical treatment methods can be divided in 4 groups. So first of all, we divide into 2 big groups like close reduction and open reduction. So you should understand what is a close reduction. Close reduction is a so-called reduction when there is no incision at the fracture site. So you can make an incision in other place and insert intramedulary rod there. But if you are not opening the fracture site, this is considered to be a close reduction. And open reduction, when you are opening the fracture site, when you can see this fracture, when you can see fragments, when you can reduce them in direct way. Of course, this is the most convenient for a surgeon way to reduce, but we consider nowadays that close reduction is better as it is less invasive and conditions for fracture healing is much better for closed reduction. So also these surgical methods are divided into other groups as internal fracture fixation and external fixate. So for internal fracture fixations, we can use various devices, different types of plates. We will discuss these types later. We can use intramedulary nails of different types. We can use screws. We can use K-wires. And all these things are implanted inside. For external fixator, there are several types as Ilizarov technique, ring frame is applied. You can use shunt screws and rod fixator, and you can use a hybrid fixation when you combine K-wires and shunt screws. So as you see, actually 4 main types for treatment are possible. It may be close reduction with internal fixation, close reduction with external fixation, open reduction with internal fixation, and open reduction with external fixation. So what are the main advantages and disadvantages? Of course, every method has advantages and disadvantages, and if we are talking about ORIF, the main advantages are that we are able to see the bone fragments, we are able to reduce them better, we are able to achieve precise anatomical reduction. And in most cases, the patient can perform movement with this limb even before the fracture has healed. For disadvantages is the risk of infection. We're talking about up to 5% of surgeries when we're implanting plates, nails, screws can be complicated. We have the risk of some other complications like complications due to general anesthesia, complications due to wrong surgical technique, problems with wound healing, fracture of the devices, and many other things are possible. These things are very rare, these complications are quite rare, but we should remember about them, and of course if we keep to our correct surgical technique, we can much reduce the rate of these complications. Of course, another disadvantage for surgeries is that we are damaging some structures, we are damaging some vessels, tissues, and so on. But we are doing this for those cases when we should restore the anatomy better. So what are the main indications for open reduction and internal fixation? First of all, we are talking about displaced intra-articular fractures. As we know, these fractures should be reduced very well, so up to 1 or 2 millimeters of displacement or impression of the articular surface. We are trying to correct. If this displacement is more than 2 millimeters, we should correct this in a surgical way. And in this way, we can reduce the later osteoarthritis for this joint, the rate of osteoarthritis. And of course, the early motion in the joint prevents its stiffness and restore its function and range of motion. Also, if we're talking about unstable, displaced fractures of the shaft of different bones, in many cases we can't immobilize them very well without surgery. That's why we're using nails, plates for internal fracture fixation. Some fractures are such fractures as femoral neck fractures, for example, should be operated in all cases, because only if you will reduce these fractures and you'll fix it with screws, that's for forearm fractures or calcaneus fractures in many cases, you can achieve proper healing and proper function. And of course, in many cases, we have a choice. We can treat the fracture in a non-surgical way or surgical way, and we should talk with the patient and his relatives. So we talk about advantages and disadvantages of each method of treatment. But nowadays, most of the patient, if they have a choice, they choose a surgical method of treatment, as they can stay in hospital just for a few days, not weeks and months, and can restore their function and start their rehabilitation just in few days. Due to this, most of the patients nowadays are treated in a surgical way. So, which devices we can use for fracture fixation? First of all, K-wires. These are thin wires that they can go in diameters of 1.0, 1.25, 1.5, 1.6, 1.8 to 0. So these K-wires can be used for fixation of small fragments like fingers, metacarpal bones. These can be used also for preliminary fixation of some fractures before you apply a plate. As well, we use K-wires of 1.5, 1.6 millimeters in diameter. We use them to apply a skeletal traction. And K-wires of 2 millimeters diameter are used in Ilizarov frame, in basic rings and in reduction rings. So application of Ilizarov frame requires K-wires of this diameter. So when we will talk about screws, these are very commonly used, maybe used alone, or also these can be used in combination with the plates and intramedullary nails. And the newest devices that we use nowadays are biodegradable devices. So we are using them already. We are still using them quite carefully as any new method, but there are some specific indications for these devices that can be used. So this goes usually in pins, these like K-wires, but of higher diameter. Usually a diameter is 2.7, 3.2, 4.0, 4.5, and screws which goes of the same sizes as metal screws. So here you can see a clinical example of tibial condyle fracture which is fixed with screws, and the scheme of the femoral condyle fracture which is also fixed with compression screws. So the screws can go in different diameters. The smallest one of 2 millimeter diameter is used for hand fractures, metacarpal bones, phalanges. The diameter 2.7 millimeters is used together with plates of the same small size. Can be used for fractures of distal radius, for example. We have two other common sizes for screws as 3.5 and 4.5. So 3.5 is used for tibial bones, forearm, and 4.5 can be used for such bones as femur. As well, when we're talking about femoral neck fractures, a specific, more powerful screws of diameter 6.5 or 7 even millimeter should be used to fix femoral neck fractures. So you see that the screw can go with a thread. It may be a fully threaded screws or partially threaded screws, and partially threaded screws has the possibility to perform compression between fracture fragments, so-called lag screws. So we can also have so-called cannulated screws, especially for femoral neck fractures, when we insert in KY, and then along the KY we're inserting when setting this screw. So internal fracture fixation with K-wires can be used also for big fractures if you use a bundle of them, like humeral shaft, and it can be used as Weber technique, K-wires and tension band. This is common technique for olecranon and for patella. So internal fixation with plates was quite long, quite old technique. First application of plates was at the beginning of the 20th century, and for these times it was just straight plates, and actually this surgical procedure were very rare. Now we have some already few generations of plates according to their design and according to their function. So as you see in this slide, there are plates already that are not straight, as a bone anatomy of almost every bone, especially for metaphyseal fractures, this is quite complicated. So these are plates that are anatomically pre-shaped already. It goes according to the shape of the bone. If you need, you can make different shape, but usually it can be used well, and this is a huge benefit, of course. If we're talking about the function of the plates, so these plates can be of dynamic compression plates and can be of locking compression plates. So you see here also other types of plates as low contact plate on the left side, when the contact with the bone is limited and these plates don't cause necrosis on the surface of the periosteum, which is very important. So the contact surface was decreased. On the middle you can see some so-called reconstruction plates. You can change their shape easily in all planes. And on the right side, different types of specific T-shape, L-shape plates, which can be used for some specific region, as condyles, tibial condyles, maybe malleolus, and so on. We should also talk about the plates that were invented in our university, and this is one of these. This is so-called DPR plate, the rotational plate by Rublenik. So it was designed here, and we made a lot of surgeries by means of these. This is a plate that can provide a stability in two planes. So you see on the right side, you can fix shaft fracture, you can fix metaphyseal fractures of almost every bone, and actually the stability is very good, as you inserting screws in two planes, in sagittal plane and in coronal plane. This is a new generation of plates, actually the newest generation of plates, so called LCP plates. That's a trademark of Synthes company. So we have many other plates of different other companies which are of the similar design. So we call these plates plates with angular stable screws. So if you look at the holes of this plate, you will see that there are the two types of screws can be inserted here. Actually, we have a green screw, which has a thread in its head, and there is a thread in the plate as well. And this is a so-called locking head screw. And another screw is inserted in right part of the plate. It is compression screw. It means that if you insert in this screw and tightening it, it can cause a compression of bone fragments. Now actually this plate can provide either compression if you need it, or stabilization, which is quite good, especially for old people which has osteoporotic bone. So for these people, these patients, LCP plates have a good are good options. Here you can see some other devices that were invented in our university. These are so-called polyimide 12 devices. So this is polymeric material which was investigated in our department, in our university, and we made many surgeries, internal fracture fixation, and even prosthetic devices were made of this material. It is highly bio-inert and it can be present in the human body for many years without any problems. Actually, we did a research according to this, so up to 20, 30, even 40 years, these screws are safely present in the bone tissue after fracture healing, and there is no only complications or adverse reactions. These are another polymeric devices that are made of PGA. This is another type of polymer, which is polyglycolic acid. And we also invented and designed some devices like pins, conical pins, cylindrical pins, and screws for fracture fixation. As you understand, these devices are bioresorbable, and after the fracture has healed, in some period of time, these devices are also resorbing and are replaced with the bone tissue. We're talking about small devices like small conical pins. It's usually 6 months needed for their total bioresorption. For big devices, for screws, 2.5, 3 years are usually needed for their biodegradation. We also have some biodegradable devices of new generation already. This is PGA, PLA copolymers, and they are presented in our market by biotech company. So we use this nowadays for fixation of different types of fractures, like tibial condyle fractures, malleolus. Note that if you make an X-ray on the right lower corner, you can see the position of bone fragments, but actually there are two biodegradable screws inserted. So these are hardly can be seen on X-rays because these are made not of metal and polymer, and it is not seen on X-rays. So you can see them on MRI or CT scan if needed, but actually we can see the position of bone fragments, and we can't see, we can see only the canal where these screws were implanted. There are also some pins made of this copolymer. We use these for fixation of metatarsal bones, or we can use them for wrist and fingers as well. So of course, the huge advantage is that you should not make another surgery to remove these, but still the indications are quite restricted as there is no plates made of this material. So most of the fractures, like shaft fractures, we can't use these devices. Now let's talk about intramedullary nails. So these are actually nails or rods, you can call them rods or nails, that are inserted inside in the canal. Every tubular bone has its intramedullary canal, and such big bones as femur, tibia, humerus, Even forearm bones can be fixed with intramedullary nails. It can provide good stability, quite early rehabilitation, but there are some peculiarities of the application that we should discuss with you, and of course different types of these devices. So one of the first was so-called Gunshot nail. That was a nail used maybe 60, 70, 75 even years ago. So it was inserted in the canal, but there were no possibilities to perform blocking. So you see on these slides we are inserting special screws perpendicular to the nail. Actually there is a hole in the nail and we are inserting it in this hole, and it gives us additional stability. It is rotational stability, stability in axial plane, in stability in frontal plane and sagittal plane, and healing process is much better for this technique. We also have nails which can, when we can perform blockings, and we can perform the dynamization later. So if you are setting these screws in the oval hole, or later the dynamization is possible. As well, these nails are divided according to the material. They can be made of stainless steel or can be made of titanium as well. And according to the location, there are specific types of nails. At tibial nail, it has some curvature, you see on the right side, on the right picture. We can also have a special nail for proximal femur. We call it a hammer nail, because intramedullary nail is fixed in the neck of femur with a special screw. And if you look careful, it looks like letter hammer. That's why the name is a hammer nail. And there were many devices designed in the same way. There were reconstruction nails, short reconstruction nails, where now we use proximal femoral anterotational nails, PFNA, which is maybe the newest generation of these nails for proximal femur. We also developed some intramedullary nails in our department. These are so-called metal polymeric nails. The principle is the same, but you see that window in the distal part of nail is fixed with a screw, but screw goes not through the hole, but through the polymeric insert. It gives us a huge advantage, because the distal locking procedure is very quick, and actually we can do it even without image intensifier, without X-rays. When we see that we're drilling the hole and the polymer goes out, we understand that we are inside, and actually it's much easier to insert screws in this window than in a small hole in the nail. So a few words about external fracture fixation. This is a father of this method, so-called compression distraction osteosynthesis. And actually he developed the frame and the principles of its application, as well as principles of treatment complicated cases as non-healing of fractures, or infections, osteomyelitis, open fractures, etc. So the idea is that, first of all, we are not inserting any metal device in the fracture site. You see in the middle of the frame there's a fracture, and all rings are applied either above it or either below it. Second principle is there are threaded pins on the sides, and you can adjust the position of bone fragments. So actually you can perform correction, and if there is some deformity, you can apply this device, and slowly, every day, gradually, you can reduce and correct the deformity. Another thing that we can do here, we can make some, by tightening these knots, we can apply some compression, and we can apply some distraction on the fracture side. It is very useful if we have non-unions, so we can compress it and distract it, and that will stimulate fracture healing. As well, if we have osteomyelitis, we have defects of bones, we can also perform, first of all, compression, and then we can make a distraction and grow a new piece of bone by means of this method. So there were many devices like that developed later. You see, this is a Hudushouri external fixator. It's like a semi-circular frame, and K-wires are used except of as well here, but it's more comfortable because it goes only on from one side of the limb, but of course it has some limitations for it. And there were many other frames developed by other authors, like Kaunsberg device, Kaunsberg frame, Tkachenko external fixator, Volkov-Oganessian external fixator. You can see that almost all these devices looks very similar, except this one, because there is hinges on both sides of the frame and movement in the joint is possible. So usually this is used for fractures which are involving the joint or intra-articular and require early movement in the joint. And this is the simplest Hoffman-Wagner external fixator, and now most of Roth's external fixators are used according to this design, were developed based on this design. These are clinical examples how we can use Roth external fixators and how we can use Lazarov frames for various conditions. So for distal tibial fractures, we can use it as temporary fixation, and we also can use it for treatment of osteomyelitis and open fractures. These are a way how we can fix up to 3 and even more fractures if we have a patient with a polytrauma. Remember, this is the treatment of choice. So we have many fractures around the body, and patient in a hot and severe condition, we should immobilize them with external fixators, as this technique is minimal invasive and quite quick. And this is a set of external fixators, frames, shunt screws, clamps, and rods that you can actually build any frame you need for specific fracture location for your specific needs.